Hi everyone. Thank you for taking time to listen to our MRI group presentation on MR Lymphangiography. Our group is led by Wilson and me, and our speakers are Julianne, Anya, and Judy, our MRI Taimei team. And we are thankful for the work they've done to put this content together. They will be talking about the anatomy and different pathologies of the lymphatic system, the different modalities that are used to image the lymphatic system and how they compare with MRI, and finally the whole process of how we perform MR lymphangiography in SGH. So please enjoy and be enlightened by their presentation.
Hi everyone, my name is Julian. Today we are here to give a presentation on lymphangiography. I will start with some general information related to this topic. My presentation is divided into two sections, the anatomy and followed by the pathology. Let's begin with anatomy first. I will touch on the lymphatic system, the function itself, and the flow later. We all know that the lymphatic system is a vital part of the immune system. The lymphatic system consists of lymphatic vessels, lymph nodes, and lymphoid organs and tissues. So what is lymphatic vessels? As you can see from the picture over here on the right hand side, lymphatic capillary originate in tissue as tiny blind-ended sacs. It lies side by side with blood capillaries. These small lymphatic capillaries merge with others to form larger lymphatic vessels and eventually empty into the bloodstream by a series of ducts. Next will be lymph, which has some features listed below. Lymph contains infection-fighting white cells and travels through the lymph nodes. It is a clear watery fluid that resembles blood plasma. This fluid contains oxygen, proteins, and other nutrients that nourish the tissues. More importantly, we need to be aware that it is not actively pumped by the heart, so the fluid pressure is very slow. The lymph movement is largely depends on skeletal muscle activity, and lymph have one-way valves to keep the lymph moving toward the heart. Next, I will move on to the lymphatic ducts. So there is two major collecting ducts formed by the convergence of larger lymphatic vessels called lymphatic trunks. Two collecting ducts drain all lymph fluid back to the blood. The overall drainage system of the body is asymmetrical. The right lymphatic duct receives lymph from only the upper right side of the body. The lymph from the rest of the body enters the bloodstream to the thoracic duct by all the remaining lymphatic trunks. Next will be lymph nodes. So how many lymph nodes in the body? Humans have about 500 to 600 lymph nodes throughout the body. It is widely distributed throughout the body along the lymphatic pathways. A network of lymph vessels connects them together. The lymph nodes are small bean-shaped structures, usually less than 2.5 cm in length, and lymph nodes are often clustered in areas where the lymphatic vessels branch off, such as groin, armpits, and neck. What do lymph nodes do? Firstly, all substances transported by the lymph pass through at least one lymph node, where foreign substances can be filtered out and destroyed before fluid is returned the bloodstream. Secondly, in the lymph nodes, white blood cells can collect, interact with each other, and with antigens, and generate immune responses to foreign substances. Thirdly, important in hemopoiesis as it is main supply of lymphocytes. Lastly, will be lymphoid organs and tissues. The lymphatic system is commonly divided into the primary lymphoid organs, which are the sites of B and T cell maturation, and the secondary lymphoid organs, in which further differentiation of lymphocytes occurs. I would now like to turn to the function of the lymphatic system now. The lymphatic system helps maintain fluid balance in the body by collecting excess fluid and particulate matter from tissue and depositing them in the bloodstream. In addition to its key immune function, the lymphatic system also absorbs fat from the gut and extra fluid from all over the body. In this respect, the lymphatic system plays an important role in lipid transport and maintaining a viable blood pressure. It also helps defend the body against infection by supplying disease-fighting cells called lymphocytes. Lymph is filtered at points called lymph nodes, where the pathogens are removed before the fluid is returned to venous circulation. The next slide is about the lymphatic system flow. The lymphatic system is similar to the arteries and veins of the circulatory system. This graph shows you the differences of three systems. Arteries are blood vessels responsible for carrying oxygen-rich blood away from the heart to the body. Veins are blood vessels that carry blood low in oxygen from the body back to the heart for reoxygenation. The lymphatic system collects and returns excess fluid from all over the body, filter and concentrate it, and then return it back into the blood circulation. From this slide, you can see the relationships between three systems more clearly. As just now what I said, the arteries bring the blood away from the heart, the venous system carries the blood back, and the lymphatic system is like the extra system linked together with another two to return the excess fluid back. To summarize it, the blood plasma passes through blood capillary walls at the arterial end. As the interstitial fluid begins to accumulate, it is picked up and removed by tiny lymphatic vessels. As soon as the interstitial fluid enters the lymph capillaries, it is called lymph, and lastly return to the blood. So what if the system goes wrong? What will happen? They say either the nose, duct, vessel or lymph have some issue, as in being blocked, infection, inflamed or cancerous or anything. When there is a problem mentioned above, the lymphatic system may not carry out its function adequately. This leads me to my next point, lipidology. We categorize it into three groups. Firstly, blockage and obstruction. Any disruption of lymphatic flow can lead to edema. Obstruction may result from scar tissues that develops when the lymph vessel or nodes are damaged or removed during surgery, by radiation therapy, by injury, or by infection with a threadworm. The lymphedema. Lymphedema is a condition in which excess lymph fluid builds up in the body. It can be either primary or secondary. This means it can occur on its own, which is primary lymphedema, or it can be caused by another disease or condition, which is known as secondary lymphedema. Secondary lymphedema is far more common than primary lymphedema. The patient's skin may feel tight and hot, and it often happens in arms and legs. Some treatment can be applied to reduce the symptoms, such as compression, routine skin care, limb exercise, or massage therapy. Moving on to the next slide, Elephantitis. Elephantitis is caused by undertreatment of lymphedema. So same thing that we mentioned in last slide. If you have it, your arms and legs can swell and become much bigger than they should be. Your sex organs and breast may also swell up. The affected skin can thicken and harden to look something like an elephant skin. It's more common in tropical or subtropical areas and usually is spread by mosquitoes. Second group, we will talk about infection, the lymphadenopathic. Infection may cause swollen lymph nodes because the lymph nodes are inflamed. The nodes may fill with pus, creating an abscess. The skin over the nodes may be red and streaky, and the most common type is lymphadenitis. Lastly, we move on to the cancer, the lymphoma. Lymphoma is a cancer of lymph nodes and occurs when lymphocytes grow and multiply uncontrollably. Signs and symptoms of lymphoma may include in this graph, like fever, swelling of the face and neck, excessive sweating at night, lump in your neck, armpits, or groin area, and so on. So there are several different types of lymphoma, including the Hodgkin's lymphoma and non-Hodgkin's lymphoma. How to tell the difference between these two groups? By examining the cancer cells under a microscope. If in examining the cells, the doctor detects the presence of a specific type of abnormal cell called a Ring-Sternberg cell, the lymphoma is classified as Hodgkin's. If the Ring-Sternberg cell is not present, the lymphoma is classified as non-Hodgkin's. Below is the chart that I compare these two lymphoma. So it happened to different age group, occurs in different places as well. The more interesting thing is that the Hodgkin lymphoma is often diagnosed at an early stage, and non-Hodgkin's lymphoma is typically not diagnosed until it has reached a more advanced stage. That's why the two lymphomas have different prognosis. I would like to hand this presentation over to the next speaker, Anya. Thank you for your listening.
Hello, I'm Anya. I'm going to talk about some diagnostic modalities that are commonly used to diagnose for lymphedema or find out edema. Total have 4 modalities, including duplex ultrasound, ICG lymphography, nucleic medicine lymphangiography, and MRI lymphangiography. I will touch on the procedure, lymphedema staging images, and also their advantages and disadvantages. First is duplex ultrasound. So as we all know, ultrasound is a simple, non-invasive, and readily available imaging test for the blood vessels. Also allows an assessment of soft tissue changes like edema, but can't give information about anatomy of the lymphatics. So normally for some patients with upper or lower limb swelling, the reason why the doctor ordered an ultrasound scan is because they wanted to exclude some venous system problem, usually used to detect obstruction or reflux in the venous system in order to demonstrate a venous pathology alone or in combination with a lymphatic abnormality. So duplex ultrasound scanner combined both beam mode and pulse width Doppler technique can provide high-resolution views of both deep and superficial venous system and flow information at the same time. On the beam mode images, the vessel will reflect ultrasound, so appear white. The blood flowing in the vessel, a soft ultrasound, so in all directions, so normally the vessel will appear dark. The non-flowing blood and thrombocytes appear as heterogeneous areas of gray echogenicity within the vessel. For the pulse width Doppler imager, the vessels with flow are colored red or blue in different directions. This will help to increase the sensitivity and specificity of the examination. In SGH, For ultrasound upper and loading scan, the common indication is to rule out DVT. DVT indicates deep venous thrombosis. It's one of the reasons that might cause upper or lower limb swelling. On the left-hand side are the order name and the phone for sonographer to point out which vein or area might have DVT. And right-hand side is to show some normal and abnormal images. So A and B are the images of normal femoral vein without and with compression. C and D are the acute femoral vein thrombosis without and with compression. Compression means they will use the ultrasound probe to press on the vessel. So on the image A, the arch means archy is anterior to the vein. After compression, the vein is completely collapsed, indicating normal compressibility. On image C, the star shows heterogeneous and expands the vein. On image D, after compression, the vein doesn't collapse, but has an overall shape, indicating an acute DVT based on the non-compressible but deformable vein. So during the scan, if sonographers see any area have edema, they will also save additional images for doctor to report. So there are the subcutaneous echogenicity grade of edema. The images from left to right are the normal to severe grade. As lymphedema progresses, the dermis becomes thicker, cones of tissue extend both towards the surface and into the subcutaneous tissue because of increased number of fibers. From normal to grade 2 image, the echogenicity is increased, and echogenic light can't be really seen on the grade 2 image. So ultrasound advantages is this is non-invasive technique, also no radiation exposure, moderate penetration depth, and readily available imaging tests, also low cost. The disadvantages is limited measurement range, only can focus at small region or area. Also limited information to diagnose, normally used to exclude vessel problem, example for DVT or find out edema, but can't give enough information to diagnose for lymphatic disease. Also, different radiographers have different skills, so this is an operator-dependent technique. Next, we'll move on to ICG lymphography. So, what is ICG? The full name is indocyanine green solution. It's one kind of contrast used in medical diagnostics. The contrast media has a peak spectral absorption at about 800 nanometers. The ICG also binds tightly to plasmon proteins and becomes confined to the vascular system. Also, a rapidly excretion from the body through the hepatic system. So after the injection, the ICG solution is actively taken by the initial lymphatics in the dermis and transit to collection lymphatics through a series of lymphangial or segments of pumping vessels that conduct lymph to draining lymph node basins. And also will use the near-infrared fluorescence image system to collect the data and generate dynamic lymphatic image. So about the ICG procedure, normally we'll prepare 2.5 milligrams per milliliter ICG solution. Use 0.1 to 0.2 milliliter of the solution, inject into a wet space or joint like wrist or ankle. The region of interest is then illuminated with a light source emitting from 760 to 780 nanometers. The images in the near-infrared spectrum at 830 nanometers. So the dermal and subdermal lymphatics can be identified to an approximate depth of 1.5 to 2 cm. Both early transit phase and late plateau phase will be recorded in the system. In a healthy patient, the flow through lymphatic vessels can be observed immediately. If a vessel are damaged, the dye will reflect into the interstitial tissues and shows the dermal backflow. So after the ICG injection, we'll start the scan immediately or after 5 minutes time to get the early transit phase. And after 2 and between 72 hours can collect the late placido phase. So at the early transit phase, the lymph pump function is evaluated by ICG velocity, and late phase is to show the pathology of the staging and the lymphatic mapping shown on the image. On the right hand side, there are 2 videos to show the early transit phase. These 2 are real-time images, can measure the ICG movement directly. So next slides will show the late placido phase and how to staging for lymphedema. The images from left to right are the progression of lymphedema. Normally, the functional lymphatic vessel will appear as normal or linear pattern. With increasing disease severity, the pattern visualized progress from linear to diffuse. The spurge pattern considered as reversible lymph backflow. This kind of pattern usually seen around the groin area, and the stardust or diffuse pattern are considered as irreversible lymph backflow. Next slides will show some real cases. On the stage 0 image, the linear pattern is seen without any dermal backflow patterns on the images. And the right hand side, the stage 1 image, can see the linear pattern, also the spottage pattern seen around the groin area. On the stage 2 and stage 3 images, they will divide the lower extremities by 3 regions: the thigh, the lower leg, and the foot. So on the stage 2 image, can see the linear pattern plus stardust pattern at the thigh area. Stage 3 image can see the linear pattern plus stardust pattern at the thigh and lower leg area. And stage 4 can see linear pattern plus stardust pattern at the thigh, lower leg, and foot area. So this is the difference between stage 2, 3, 4. They will divide by 3 regions. On the stage 5 images, can see only diffuse or stardust patterns, don't have any linear patterns seen. This is how they staging for lymphedema. So advantages and disadvantages for ICG lymphography is, this is a valuable superficial lymphatics. Also, no radiation exposure, low cost, can use on the diagnosis and surgical planning. Also, suitable for intraoperative guidance. The disadvantages is limited to superficial lymphatics, unable to observe lymphatics while the soft tissue is thicker than 2 cm, so difficult to be used on some big size patients. Also time consuming, might need to take more than 6 hours, and operator dependent. The last is unknown side effect. Because the ICG contrast raised some concern because of the lack of studies about the side effects. So next is nucleic medicine lymphocytography. In many disease status, functional changes occur or become visible before anatomical changes. So among the image techniques, lymphocytography has been widely considered as the main modalities to diagnose for lymphatic system problem. So lymphocytography commonly used to identify the sentinel lymph node. can see the picture below. Sentinel lymph nodes are the first nodes to receive lymphatic drainage from a tumor. Can do a biopsy on the sentinel lymph nodes to find out whether have any spread of cancer, normally used for breast cancer patients, and also used to identify blockages in the lymphatic system that might cause lymphedema, which results swelling of the extremities. So about the procedure, patient is positioned on the examination table, which slides in between two parallel gamma camera heads. 1.5 to 2 millicurie of TC99 is injected into a wet space, each side once, inject into first or second wet space. The gamma camera takes a series of images after radio tracer injection. Example for lower extremities will start from foot, move up to calf, thigh, and pelvic area within 15 minutes. You can see the images below. And both the swelling and healthy arm or leg will be imaged so that the both sides can be compared. And the computer helps create the images from the data obtained by the gamma camera after the injection. So there are the delay phase at 30 minutes and 1 hour, including whole lower body. Also the 2 hours delay phase. Depending on patient's condition, doctor might request for latest delay images, up to 4 or 6 hours. So the photo on right hand side is to show some causes and patterns for lymphedema on the lymphocytography images. Cause lymphocytography images using radio tracer so have high specificity to focus on lymphatic system. Means on the images for lower leg only will show the lymphatic vessel. Next is the staging of the lymphedema. On the lymphocytography, the image can see the lymph node uptake, any dermal backflow, collateral lymphatics, main lymphatics, and measure the clearance of radioisotope from injection site. So on the grade 1 images, compared with the left leg, the right leg with madly decreased lymphatic transport function, decreased lymph node uptake at pelvic area, minimum lymphatic retention, and dermal backflow are seen on the image. Also, the main vessel still appear normal. The left leg shows no advance of lymphedema with normal lymph node uptake, no dermal backflow, and well-visualized main lymphatic vessels. So move on to the grade 2 images. The right leg with partial lymphatic obstruction, image shows much decreased lymph node uptake and a small amount of dermal backflow extending 1/2 of the extremity. Scanty collateral lymphatics and almost no visualization of the main vessel. On the grade 3 images, the right leg with severe lymphatic obstruction. Image shows no lymph node uptake, non-visualization of the main lymphatic vessel. Also can see a big amount of dermal backflow. Move on to the grade 4 images. Can guess which side have problem? Yeah, it's left leg with nearly non-functional lymphatics. Image shows no lymph node uptake, non-visualization of the main lymphatic vessel, and no dermal backflow. So the advantages for lymphocytography is this is a high specificity technique and also provide both qualitative and quantitative analysis, including you can see the lymphatic system alone on the image. Also can measure lymphatic flow and diagnosis for the lymphatic obstruction. Ability to assess lymphatic function and also can use on the diagnosis and surgical planning. The disadvantages is the radio tracer have radiation exposure, might need to take concern for pregnant and breastfeeding patients. Also, the images has poor anatomic resolution. Can't see any soft tissue on the images. An inability to access interstitial tissues. Also, it's a time-consuming scan. Depends on patient's condition. Might need to take up to 6 hours. And also high cost. Okay, so the last is MRI lymphangiography. The procedure of the lymphangiography will be presented by Judy later. For this part, I will talk more about the performed sequences and what usually will mention in the report. So the first, we are using a coronal T1 VITE Dixon facet pre and post contrast images. As we know, the VITE is a radiofrequency spot gradient echo sequence, can produce the T1 vector 3D images, and particular to use on the body cases or extremity 3D imaging. The blood vessels and pathologies with high vascularity appear bright on T1 VITE facet postgate images. So you can see on the right side, this is a coronal VITE Dixon facet postgate 6 minutes image. You can see on the arrow point out. The doctor compare with the axial recon, then say this is a dermal backflow. So also can use these sequences to meet the images and can see the enhancing lymphatic channels more clearly. So this sequence usually used to visualize the dermal backflow and enhancing lymphatic channels. The another sequence is coronal T2 turn space. We'll do this sequence at post contrast. So space is a variant of 3D turbospin echo sequence, can produce a high resolution isotropic images. Means can be reconstruction in multiple planes. Also less sensitive to susceptibility and flow and chemical shift artifacts. So normally we'll use the coronal T2 turn space and axial recon images to define the severity and extent of edema. You can see on the right hand side is coronal turn images, and below is axial turn recon from the coronal turn. And another one is MR venography. We'll do post contrast. So this MRV is an additional sequence by request by doctor. For MRI scan, we are using gadolinium contrast. The contrast is the water soluble and the diffusible. So normally when we injection, the vein also will seen present on the MRI images. So MRV can help to differentiate the subdermal lymphatics from the vein, normal vein. There are two images. One is mid images, another is MRV. So on the mid images, you can see the arrow and arrowhead point out the vessel, but can't tell which one is the normal vein and which one is the lymphatic vessel. So if we do the additional MRV sequences, can see the arrowhead points is the lymphatic vessel and the arrow points is the normal vein. So this sequence is used to further differentiate of the superficial veins from the lymphatic channels. So normally on the MRI lymphangiography report, we'll mention few things. The first is the presence, severity, and the location of lymphedema. Also, the number 2 is a number, diameter, cause from the skin or both affect lymphatic vessel and the nearest vein. Number 3 is the lymphatic drainage pattern. Have 3 types. The type 1 is a poor lymphatic drainage or diffuse interstitial enhancement. It can see on the images have very bad dermal backflow. So the type 2 is partially diffuse enhancement or interstitial and vascular enhancement. You can see a slightly like the honeycombing pattern. And the type 3 is direct. It's lymphatic enhancement without any dermal backflow. So on the right hand side, the coronal validation facet shows its type 2 images with slightly honeycombing pattern. And number 4 is the delay of drum age. They will compare the post-contrast 20 minutes and 6 minutes or more delayed images to measure after the injection how long have the contrast enhancement from the foot area to the pelvic label. So they will measure the timing, have scored 0 to 3. And number 5 is the detection and localization of lymph nodes. They also will compare the postgate on the 20 minutes or 6 minutes delay phase and compare the right and left lymph nodes or single site have any lymph node enhancement. On the delay phase, they will see any washout of the contrast. The 6 also the presence of venous contamination. So the advantages for the MRI is no radiation exposure, also high anatomic resolution, and ability to assess lymphatic function and can do the 3D reconstruction. Also can use on the diagnosis and surgical planning. The advantages is MRI have some safety issue. Maybe for some patients have pacemaker or some device can't be used these modalities. And also time consuming. Depends on patient's condition, might up to 4 to 6 hours. Also potentially patient unfriendly. Patient have to keep still for few hours the entire scan. Also is a high cost. So this is a comparison for the 4 modalities. The different modalities focus on the different things. Also, some can use on the diagnosis, some can't be used for diagnosis alone. The time consuming for the ultrasound is fast, but others all quite long. And some have contrast injection, some don't have. So depends on the patient's condition. The doctor will choose the correct image modalities to diagnose for lymphatic system disease. Okay. So next, I will pass to next speaker, Judy. Thanks for the attention.
Hi everyone, I'm Judy. I'll be talking about preparation and application for MRI lymphangiography. Here is the overview protocol and workflow for our department MRI lymphangiography procedure, and I'll elaborate more later on. So we'll start from the preparation first. Before scheduling, we have to check with Dr. Approval if the scan is really needed and his availability as we need him to be around for the scan, and inform patient to reach at least 1 hour before the scheduled time for preparation. For the billing wise, we'll build it as MRI right or left upper limb lymphangiography or MRI left or right lower limb lymphangiography. Total, we can get 5 slots. For bilateral lower limb, we can do on the same day with same setting. However, for upper limb, have to do separately on different date. And here is the MRI lymphangiography accessory list. On the day of the scan, we'll get this list for MRI nurse to prepare all the required accessories. After everything prepared, get patient lie down on trolley and apply MLA cream at weight space at least 1 hour before the scan to numb and decrease the pain of injection site. And after that, use Tegaderm to cover so that MR cream won't be lost into surroundings. To take note that patient may encounter side effects from MR cream such as difficult breathing, swelling or redness. So watch out patient closely after apply MR cream. The picture 3 shows that toes and fingers waste space for injection procedure. And here is the consent form for MR lymphangiography. Allow patient to read through consent form first and inform doctor approval to take consent before the scan. Also, we have to put the positioning marker for patient. There's few landmarks for marker placing. For lower limb, there's ASIS, tibial tuberosity, and medial malleolus of ankle. Upper limb, there's AC joint, lateral epicondyle of elbow, and wrist joint. After put a marker, we use the durable to secure marker and get the skin marker pen to mark out the marker on patient's skin. So if need to remove markers, temporary or marker move, we have the reference for the same spot to put it back. And there's 5 centimeter interval between each markers. By placing the markers, it can help our radiologists to know how fast and how far has the contrast been taken out by the lymphatic vessel. And come to the pre-contrast scan. For upper limb, we'll use head first supine, arm supinated, cover from AC joint to hand. Use spine coil and 2 to 3 body coils. Lower limb will be feet first supine, leg internally rotated. Cover from ASIS to foot. Use spine coil, body coil, and also peripheral coil. Do chrono T1 vibe disinfect sequence. This is how the room set up for lymphangiography scan. The figure 1 is upper limb, figure 2 is lower limb. And we'll come to the injection. So after pre-contrast scan done, this is followed by the steroid injection procedure. We'll mix Gadovis 5 ml and 1% of lignocaine, which is local anesthesia medication, and 8.4% of sodium bicarbonate to buffer the acidity of lignocaine, therefore decrease the pain of injection site. Mix them together and attach the 3-way tape to the syringe. Radiologists will then draw the solution into 1 ml dual lock syringe and connect each syringe to 27 gauge needles. So 1 ml of solution will then inject to each waste space, followed by massage of injection site immediately, so that the contrast can be taken out by lymphatic vessel more quickly. One of radiographers should put on a sterile glove to help with the massage, while the other radiographer should communicate with patient and fill out the MR lymphangiography questionnaire, which I will show in the next slide. And the picture below, it shows how contrast media being injected to the waste space. So this is the MRI lymphangiography questionnaire. Radiographer should record the injection time and ask patient the pen score from 1 to 10 after each waste space injection. From the first waste space, second to third waste space, and come back to second time for first waste space injection. As Dr. Abuva now is not injecting the last waste space anymore because it's very painful for patient. And we also have to record down the contrast type, total scan time, fill out all the form accordingly. And come to the scanning protocol. The scanning protocol generally consists of 2 sequences, which is T2 term space sequence, in order to evaluate the extent and distribution of lymphedema. Also, the T1 VIBE Dixon FATSET sequence for lymphatic visualization. For chrono T1 VIBE Dixon FATSET need to be performed at multiple time points from pre-contrast, 15 minutes delay, 45 minutes delay, 60 minutes delay, and get doctor approval to review at 60 minutes. If need to proceed with 75 minutes and 90 minutes or even longer. However, for chrono T2 term space can be done at any time point. Usually we'll do it in between 15 minutes to 45 minutes delay, as chrono T1 VIBE Dixon FATSET takes about 10 minutes or less. So there's free time while we're waiting for 45 minutes delay. For T2 term space sequence usually takes about 15 minutes. And we'll come to post-procedure. After the scan, remember to apply plaster for patient on the injection site. And there's some post-processing needs to be done, which is axial recon for T2 term space, 1.3 mm slice times 1.3 mm gap, and axial recon for T1 VIBE Dixon FATSET, early and delay enhancement of 1.1 mm slice times 1.1 mm gap. Mid-rotate for chrono T1 VIBE FATSET, all time points. This is the post-processing image example of axial T2 term space recon and axial T1 VIBE Dixon FATSET recon. And also the mid images. From the mid images, we can see the pathological lymphatic vessel clearly, and it is important to differentiate between lymphatic vessels and veins. This image here are 5 minutes post-contrast and 20 minutes post-contrast mid images. Can see the solid white arrow here is the pathological lymphatic vessel, while the non-solid arrows are veins. We can see the difference as veins are straight, while pathological lymphatic vessels have a tutous and beaded appearance. The diameter of affected lymphatic vessels are similar to veins, but greater than healthy lymphatic vessels. Healthy lymphatic vessels are rarely visualized. In fact, under normal conditions, in a healthy lymphatic system, the lumen of vessels are almost virtual. And here, in the area of red circle, there is dispersion of contrast media in soft tissue due to obstruction of lymphatic drainage. And this appearance is also known as dermal backflow. This is the mid-rotate image example. And come to the list for passing. We'll pass raw data of chrono T2 term space and chrono T1 VIBE Dixon FATSET pre-contrast, axial recon for T2 term space and T1 VIBE Dixon FATSET early and delay enhancement. Also all the rotate for all time points, assign the case to doctor approval, and archive all composed raw images, recon images, and mid images. Now I will show some case study done in HGH. So for the first case is a 40 years old female, history of bilateral lower lymphedema tata, doing MRI lymphangiography to assess lymphatic tracts. Lymphedema tata is a genetic disease that usually affects patients after age of 35, causing defect in the lymphatic valves, which result in lymphedema. So there's 50 minutes, 45 minutes, and 60 minutes mid images. Can see the enhancing lymphatic channels. There's one main bundle of dilated lymphatic vessel highlighted along the medial aspect of right calf and thigh as well as left calf and thigh. And there's bilateral lower limb edema affecting the subcutaneous tissues. However, there's no thermal backflow as of 45 minutes and 60 minutes delay. The contrast is not retained or spreading into soft tissue. Also, there's no lymphatic delay as we can see a bit of enhancement at inguinal node at 15 minutes delay. So this is the case with type 3 lymphatic drainage pattern with directed lymphatic enhancement without dermal backflow. For the second case, is a 54 years old female, history of ovary cancer, doing MRI lymphangiography to rule out lymph edema after radiotherapy treatment. From 20 minutes, 70 minutes, MIP images and chrono T2 term space. Compare the right and left lower limb. The edema mainly over right thigh, with not significant edema of left lower limb. From T2 term space image can help to illustrate the edema even better. So on 20 minutes and 70 minutes MIP images, we can see the dermal backflow affecting right thigh. Comparatively, there is normal appearance of lymphatic flow on the left, and can see there's washout in the lymphatic vessels, also inguinal node at 70 minutes, as there's no lymph stasis of contrast media in the lymphatic vessels. So this is the case with lymphatic obstruction at right thigh, right inguinal region, with type 2 lymphatic drainage pattern showing dermal backflow over right thigh while normal appearance on the left. And come to the last case, is a 64 years old female with history of left breast cancer post-mastectomy and axillary clearance, doing MRI lymphangiography to assess left arm lymph edema. There's 20 minutes, 75 minutes MIP images and chrono T2 term space. From T2 term space image, can see the edema affecting forearm mainly, and also can see the MIP images there's dermal backflow, more significantly on 70 minutes delay. So this is also a case with type 2 lymphatic drainage pattern showing dermal backflow over left arm. Okay, that's all for our group presentation. Thank you.